I think most members are not able to see the link. Let it be reposted, please. Including your expectations, please text in your expectations. What are you expecting of us during this session and how we can make it better? Okay. Give us your expectations, please, so we get to know how to make it better for you and everyone to enjoy it actively.
For those who are unable to see the poll, please go under more or click on the polls part where you can really see it, and then you'll see it at the light will come onto your screen.
We should be winding up with the pre-tests and expectations. Okay, I see Mr. Julius is expecting to know more about the condition and refreshment. Okay, the condition is going to be brought into details during the management and the part of investigations and also case presentation. Thank you, Mr. Julius. Isa, expect to know about the upper gastrointestinal bleeding. Yes, Isa, this is going to be handled. Thank you. Okay, Mrs. Jamila would like to know about the clinical presentation, diagnosis, and management. Yes, this is going to be handled. Thank you so much.
Please respond to the polls. We are soon taking it down. Please check out the polls, and then you'll be able to see it labeled pre-test. Fill it in to enable us know how better to prepare the session.
Okay, someone expect to know how tranexamic acid is very useful in the management of ruptured esophageal varices. Thank you so much. That is going to be handled by the experts. Okay, thank you so much, everyone. We have noted your expectations, and I hope you added in your pre-test. So we are going in the next program, and that is the case presentation, which is going to be done by Dr. Nelson Mandela. Dr. Nelson, please, you are most welcome.
Thank you very much. Let me just share the slides. Kindly make me a host.
You can share, as a co-host, you can still share your screen.
It's still denying me.
Your co-host now, they can go ahead and share.
Thank you, thank you. I'm heading there soon. So thank you so much for this opportunity to present in this 146th session. My name is Nelson Mandela once again. An intern doctor at Soroti Regional Referral Hospital. Today, the 15th of September, 2023. So I'm going to present a patient with variceal bleeding, or rather ruptured esophageal varices. So I'm presenting Eddie, a 70-year-old female who was diagnosed with hepatitis C-induced liver cirrhosis at our facility here, Soroti Regional Referral Hospital, 10 weeks ago. She presented to our emergency department 2 weeks ago with a day's history of vomiting blood, which often preceded nausea, epigastric pain, and abdominal fullness. This was followed by melanoma stools, generalized body weakness, easy fatigability, palpitations, without prior evening fevers, drenching night sweats, and weight loss despite loss of appetite for unknown duration. There were no other GI or severe symptoms in that case. So we received a patient and we did our emergency assessment. The airway and the C-spine, okay, the airway was patent and the neck was stable. So we had to keep that on monitoring. Patient was on bed. That time we put the patient on.
Could you move your phone to landscape so that we can be able to see a bigger image?
A bigger image?
Yes, right now it is in portrait. You could move it. No, he said.
Pardon?
Okay.
Is it in slideshow?
Just rotate the screen and do it in landscape.
Is that better?
You could turn the phone and present in landscape.
It's already there. Is it better?
Okay. For now, you can just move on. You can see it.
Sorry for that difficulty. Yes, so the patient was not in respiratory distress, and she was tachypneic, 25 cycles per minute, saturating at 96% at room air. Her chest was clear then, auscultation. So we kept monitoring the SpO2 and respiratory rate as our intervention. Then going to saturation, at admission, we noted that the patient vomited instantly, roughly about 300 mils. There's still some complaints in the group.
Yes, you use, it would have been better for you to zoom out, tilt the phone to landscape, so that you get it exactly. Yes, thank you. You can continue.
Okay. So the patient vomited roughly about 300 mils of blood vomiters at admission, and she was diaphoretic. However, she had warm extremities. She was moderately pale, with a capillary refill which was less than 3 seconds, and she was tachycardic at 120 beats per minute, hypotensive at 85 over 50 millimeters of mercury. So there we had to get an IV access, 2 lines. That time we had gauge 18, it was available now wards. So we used that and we took off some blood samples for grouping cross-matching on a purple top bactutainer. Then on a 3-to-1, that time we had 2 liters of normal saline that we gave the patient to have her resuscitated. And the grouping cross-matching was done, blood was ready, we transfused the patient. By the end of the day, she had 2 units of blood given unto her. Part of disability, she was conscious. Yes, the SI score was 4, best verbal was 5, she was oriented. And she would obey commands at best mode of 6. So her pupils were normal size, they were equal and reactive to light, and reflexes were normal. On exposure, there were no external injuries. Still further, so the signs and symptoms that this patient had, one of them was vomiting, and we realized that this vomiting was non-projectile, and we had vomiters that had fresh blood, and it was a mixture of fresh blood and coffee brown substance, and she had it several times, often preceded nausea, abdominal fullness, and epigastric pain. The epigastric pain on description was of gradual onset, was burning, nature moderate, and it would radiate to the sternal area, and it was marked prior to vomiting and fairly relieved post-vomiting. She also noted that the patient had Milena stools, and she had 2 episodes. The first was distinct, that was prior to admission, at home. Then prior to admission, they reported that it was mixed with fresh blood. And then she also had reduced appetite. Previously, we noted that this reduced appetite has been there for unknown duration. And she had easy fatigability, palpitations, dizziness, and generalized body weakness. There were no known allergies to food, drug, or any environmental stimuli. And the reports had it that she had taken paracetamol at home, anticipating some improvement there. On her past medical history, this was her second admission. with similar symptoms. The index one was about 10 weeks ago, as previously told, at our facility, Soroti Regional Referral Hospital, where she was treated for upper GI bleeding secondary to hepatitis C-induced liver cirrhosis. So unlike this episode, the previous episode only had like two episodes of vomiting, and then in part of her management, she received a unit of blood. She was counseled about endoscopy and actually referred for that investigation. However, she deferred due to financial challenges. Then her hepatitis B and HIV serology was negative, and she had no history of NSAID use, and neither was she hypertensive. We also noted that the patient had a last meal prior to admission. However, she vomited it all, and there were no traumatic events. So on our problem list, first thing is patient was vomiting blood, and she had epigastric pain, actually moderate epigastric pain. Then there was poor food intake. Then she also had melanoma stool and an episode of hematochezia. So we did a few investigations that were within our means. And one of them, of course, was a random blood sugar. It was 4.2 millimoles per liter. She was blood group A, this was positive. And her CBC, significantly, we had there normocytic, normochromic anemia of about 8.7 grams per deciliter. Our platelets reduced 110,000 per mil. We also still wanted to check out for the alpha-fetoprotein, given the diagnosis that we have, and it was 2.45 nanograms per liter, fear of developing HCC. So realized that the patient was having epigastric pain, wanted to also rule out H. pylori infection, and we did the H. pylori stool antigen, then it was negative. A repeat of an ultrasound scan. Initially we had it, this time still, we still had liver with coarse echo texture, suggestive of liver cirrhosis, that there was portal hypertension, splenomegaly, and mild ascites then. Yes, there are some other investigations that would have done, like thrombin time for such a patient who is vomiting blood. However, means we can do. Liver functioning was done initially. This time we were unable to. Definitively, we gave the patient IV talipresin 2 milligrams, and as a start dose bolus. Then we gave her 1 milligram 6 hourly. That fine for 72 hours, not doses, please. We also, as we noted, that the patient last had a meal prior to admission, some hours prior to admission, and vomited it all. We're still worried that this patient may go to hypoglycemia. So we gave the patient 10% dextrose, and as we anticipated the improvement, and later maybe oral intake. And because the epithelial barrier was broken, with evidence that we are vomiting blood, we are fearing bacterial translocations, and so we had to cover our patient with an antibiotic. Referral, we chose IVC profloxacin, the 200 milligrams BD, and gave it for 72 hours. So by day 2, our patient was picking up. Actually, this patient was a bit impressive compared to others that we've been managing for the same. Her vitals kept improving, and this time our pulse had reduced from the 120 at admission to 89 beats per minute, and her BP was had moved up to 107/65. It was okay, and yeah, she was having 18 cycles per minute in respiration, saturating at 98% from air, and she was fully conscious with GCS of 15 with adequate urine output. So we decided to transfer our patient to the general ward. Importantly, we wanted to really continuously counsel our patient to take up the endoscopy that we had previously discussed and agreed. Because surely this patient deserves it. And because our BPs were a bit stable, we started our patient on propranolol, 40 milligrams OD for the portal hypertension. So on day 3, patient had agreed, as we discussed, to go have the endoscopy done. So, and then she was stable. So we allowed her to go and gave her oral ciprofloxacin. We anticipated that to take us a period of about 10 days. Some oral hematins of a syrup, moved forward. Yeah. So we're still waiting for the results. She has not returned back. We hope she comes back soon. Thank you so much, Elamanoi. Good afternoon once again.
Okay, thank you so much, Dr. Nelson, for a very nice case presentation. Dear members, we are having some good minutes of reactions towards the case presentation. You can raise up your hand, you will be picked, or type in your question in the chat or in the Q&A. Thank you so much. Anyone with question, you can raise up your hand or type in the chat and it's going to be read, directed to the case presenter. Okay, someone is asking the case presenter if he did consider giving the PPIs or any antacids. Dr. Mandela, you have a question?
Okay, thank you so much. PPI is indicated for these such occasions. And in our notes, initially we had given a start dose of omeprazole. Yeah. But then, okay, over time, the epigastric pain went off, so it wasn't approved further. So we ended at that. Thank you.
Okay, thank you so much. Someone also would like to know why you did make a choice of ciprofloxacin rather than any other drugs. And how about the PPIs that I think you already answered?
Okay, ciprofloxacin is quite, it's good for the gram-negatives, which normally are within our GI. And we are realizing that the breakage in epithelial lining is occurring within the GI, and we're fearing those most of these gram-negatives. So ciprofloxacin would be very good for that case. Thank you.
Well, thank you so much. Dear members, we are seeing some of the questions which are going to be answered in the management. So please, we beg for your patience as we call for the next presenter. Thank you so much. You can keep it coming if you still have any other questions. We are going to tackle the rest, and some will be brought in the management, so you will realize that your question has been answered during the course of the management. So let's go to the next agenda, where we are going to get the different causes of GI bleeding, and this is going to be done by Dr. Orit Daniel. Doctor, please, you're most welcome.
Slideshow. It's okay. You know, do slideshow. Okay, thank you very much, everyone on call. Once again, I'm Dr. Orit Daniel. I'm a physician at Soroti Regional Referral Hospital. And this afternoon, I'm going to take you on the different causes of gastrointestinal bleeding causes. And to start us up, when we look at the gastrointestinal system, excuse me. Okay, sorry for that hitch. So when we look at gastrointestinal bleeding, we all know that the gastrointestinal system is made up of the upper GI and the lower GI. And when you look at that diagram critically, at the level of the ligament of Tri, that's where we categorize it as an upper GI, and anything below the ligament of Tris is the lower GI bleeding. So later on in the subsequent slides, we're going to look at the different causes of upper GI. Then we shall have a small discussion on lower GI bleed causes. So just to take you to the next slide. Next slide. Just go. Yeah, okay, thank you. So looking at that slide that has been projected, we see two aspects. Whenever you have a patient presenting with a gastrointestinal bleeding and you're focusing majorly on upper GI bleeding, it's very important that in your mind you think of a variceal cause versus a non-variceal cause. So when you look at the slide that has been projected, on the extreme right, you see the variceal causes, and there we're simply looking at the liver structure. Starting at the inferior vena cava, getting into the liver, then we have the portal systems. Then on my extreme left, we see non-variceal causes, and in the non-variceal causes, to make it easier for you, you have to look at it right from the mouth, the esophagus, then you get into the stomach and the duodenum. Now, to go a little further in looking at variceal causes, later on I'll tap on the non-variceal causes, but to look at the non-variceal causes, next slide. Next slide. Okay, looking at non-variceal causes, when you look at, no, let's go back to the first, sorry. The previous slide, sorry. That one, exactly. Okay, so when you look at that slide, we look at the anatomical presentation of the liver, then we see the stomach, and later on we see the varices, as in the collateral vessels, that later on supply the stomach as well as the esophagus. So when you look at that diagram critically, what is of our major concern are the varices that are lining the esophagus and entering into the stomach. So now the key thing that you must all know when we talk about variceal bleeding is you understanding that there's something that we call okay, so it's very important that you put into consideration portal pressures and portal hypertension. So normally the portal venous pressures are supposed to be between 2 to 5. But then when we get conditions that affect the liver, you're going to get portal pressures rising above the recommended 2 to 5. And in this case, when you get pressures exceeding greater than 10, a patient will develop portal hypertension. So it's the portal hypertension that later on brings in the aspects of esophageal varices. And esophageal varices in most cases develop when the portal pressures exceed 10 millimeters of mercury. So what exactly happens is that when these pressures build up, you're going to get blood pushed back through the alternative routes in order to reach the heart rather than going through the liver. And remember, these varices I could say they are thin-walled, and when these pressures build, they are easily going to rupture. And the next thing that you know is that the patient is going to vomit blood. So just to take you back to take you to the next slide, let's go to the next slide. Next slide. Okay, so now looking at the slide that has been projected to you, not the previous one, sorry. No, previous. Yeah, okay, that one, sorry. So when you look at that slide, I want you to focus majorly on the variceal causes on my extreme right. So anything that is going to cause an obstruction, right from my, I don't know if you guys can see, at point 1, if you have a blockage there, let me say in form of a clot, okay? It's going to build up the pressures, and the next thing that you're going to get will be a rupture of the esophageal varices. So the cause in point 1, in most cases, is something that we call bad Chiari. A majority of you who are clinicians have heard of bad Chiari syndrome, and that's the exact cause there at point 1. Then when you look at point 2, inside the liver, the sinusoid, we have veno-occlusive diseases. Then at point 3, that's where we have liver cirrhosis coming in, because we all know that in liver cirrhosis, we have loss of the liver architecture, which also interferes with how blood flows through the liver. And at the end of it all, we're going to have a buildup of pressure, backflow pressure that gets into the varices and causes rupture. Then we also have polycystic liver diseases, metastatic liver diseases, cancer of the liver, as well as hepatomas. Then at point 4, that's where we have schistosomiasis causing liver periportal fibrosis, and still it's going to bring about a buildup of portal pressures that is going to cause backflow of blood pressures into the varices, and that's going to rupture and make the patient vomit. Then at point 5, that's where you have portal vein thrombosis. In case you have a clot at that point, still, there'll be an obstruction to blood flow, portal pressures build up, they're transmitted back to the varices, and the next thing you know, the patient is going to rupture, and later on, the patient is going to vomit blood. So when you look at the variceal causes, it's very simple. When you look at this tree, that you're going to look at those different points, in that when you look at point 1, what comes into your mind is bad carry. You look at point 2, veno-occlusive diseases. Point 3, that's where liver cirrhosis comes in, cystic liver diseases, hepatocellular cancer and hepatomas. At point 4, portal fibrosis in schistosomiasis, and point 5 is portal vein thrombosis. So that's the easiest way for you to be able to remember the different causes that bring about variceal upper GI bleed. Now, on my other extreme right, you see another diagram that looks at the anatomical presentation right from the esophagus to the duodenum. So in this case, we're going to look at the non-variceal causes. And why I want you to have a differentiation between the two is that later on, when it comes to how we manage these patients, you're going to find that the drug therapy that we give a patient who comes in with a variceal bleed is different from the drug therapy that you give a patient who comes with a non-variceal bleed. Also, other surgical interventions that you give a patient who comes with a variceal bleed is different from a patient who comes with a non-variceal bleed. So that's why I find it's very important that I give you a highlight on how to differentiate these two. So when you look at the non-variceal causes, right from the esophagus up to the duodenum, you see one, in case you get an esophagitis, chances are high you're going to vomit blood. In case you get Mallory waist tears, chances are high you're going to vomit blood. When you get gastric ulcers, you're going to vomit blood. When you get cancer of the stomach, gastric cancers, you're going to vomit blood. Then also there are other causes. In most cases, these are autoimmune causes, and you've had conditions like Osler-Weber-Rendu syndrome. You've heard of the watermelon stomach. Then there's one that has a very nice French name, de la Feu lesions. All those lie in the non-variceal causes. Then also, we can't end this particular slide without talking about viral hemorrhagic fevers, because the viral hemorrhagic fevers could also occur in the non-variceal causes, and it's very important that you must always also have a high index of suspicion, especially if the patient that you're looking out comes in an endemic area that has had viral hemorrhagic causes. Because you remember what happened in Kasanda and Mubende? I think that was in October, November, and we had patients vomiting blood. So we can't ignore the mere fact that even viral hemorrhagic fevers can cause a patient to vomit blood. So it's very important that as a clinician, just have that as a high index of suspicion always in thinking about this. Then finally, we shall also look at causes of lower gastrointestinal bleed. Ibrahim, take me back to the first slide. First slide. Not that one. Okay, that one. So finally, we shall also have to look at causes of lower GI bleed, because all this is the gastrointestinal tract. And in the lower GI bleed, like I earlier on alluded to it, we have anything that falls below the ligament of Treys, classified as a lower GI bleed. And when you look at that slide, in the lower GI bleed, you could have polyps at the jejunum. Cancer or inflammatory bowel diseases will give you lower GI bleeds. At the ileum, you can still have inflammatory bowel diseases, colorectal carcinomas, diverticulosis. Then at the rectum, you can have things like hemorrhoids. So the take-home message when you look at the different causes of GI bleeding, it's very important that first, you differentiate between upper GI bleedings and lower GI bleedings. And the differentiating point there is looking at it at the level of the ligament of Treys. Then when you look at upper GI bleedings, still very important, classify into variceal versus non-variceal. Variceal is strictly looking at the liver from the portal system supplying into the liver and getting into the inferior vena cava. And any blockage in the blood flow around that area will give you a variceal bleed. Then when you look at non-variceal causes, you look at anything that comes from the esophagus getting into the duodenum, and that's where you have things like esophagitis, malarial oysters, bleeding PUDs, cancer of the stomach, few lesions, as well as viral hemorrhagic fever. So basically, that's what I had to present on the different causes of GI bleeding. Later on, when we look at management, you'll see the rationale of why we have to differentiate between variceal versus non-variceal causes of gastrointestinal bleeding. Thank you, and over.
Thank you so much, Dr. Orit Daniel, for such a very nice different causes of the GI bleeding. Dear members, you have 2 minutes to at least give some few questions or inquiries about the case presentation. I mean about the different causes of the GI bleeding. You're welcome. You can raise up your hand or please type it in the chat section and you will be picked up. Okay, doctor, someone would like to know about the watermelon stomach, a little lights on it.
Okay, so about the watermelon stomach, like I told you earlier on, we have autoimmune diseases, and watermelon stomach is majorly an autoimmune diseases. And we all know that there are very many autoimmune diseases, but in particular, we shall focus on vasculitis. And a watermelon stomach is simply a vasculitis occurring in the stomach. So it's more of a watermelon disease. It's just a few people who are predisposed to getting an autoimmune disease, others will be predisposed to getting a watermelon stomach. It's not everyone. Thank you, and over.
Okay, thank you so much. Yes, Doctor. Dr. Kamara, you can add something to it. Thank you.
Yes, I was going to, wanted to add maybe what the person asking about the watermelon stomach was that they called it that because on endoscopy, that's what it looks like when they're doing endoscopy and they're looking at the lining of the gastric fundus and antrum. So it looks like the vasculitis looks like red streaks, like a watermelon. Yes.
Okay, thank you so much. That has an addition from Dr. Kamara. Someone else would like to know about the clinical differentiation between the upper GI and lower GI bleeding.
Okay, in clinical differentiation, I'm just wondering if the person asking is looking at the history, because in clinical differentiation, when you're differentiating these two, it may be a little difficult, but of course there are those presenting symptoms that a patient will be able to come with, like a majority of patients who have upper GI bleeding will have hematemesis, vomiting blood. Then they'll also be passing Melanor stools, okay? While a majority of patients will have lower GI bleedings, in most cases they'll have blood in stools, okay? Then we shall also have them having hematochezia, and we can't rule out the mere fact that some of them could also have Melanor. So in most cases, just to make it simple for you, is that when you look at it on the clinical aspect, upper GI in most cases is hematemesis. You vomit blood, then you have black stools. While when you look at lower GI bleedings, it majorly it's blood per rectum, as in blood in the stools. Thank you, and over. I hope I answered your question. Thank you.
Thank you so much, Dr. Daniel. So dear members, you can please type in your questions in the chat as we go to the next presenter. We are going to read out your questions later on. So at this time, let us welcome Dr. Kamara, who is going to take us in the assessment and investigation of a patient with GI bleeding. Doctor, please, you're most welcome.
Okay, thank you again. I'm Dr. Kamara, emergency medicine resident here too. I'm going to take you through the assessment and investigation of a patient that presents with upper GI bleed. So you can go to the first slide. As always, we start with the ABCDE. When a patient comes with bleeding of any sort, we start with ABCDE. In this case, we are going to pay special attention to hemodynamic stability because we are dealing with a GI bleed, but nonetheless, we go through ABCD. And as you go through the ABCD, you're asking yourself, is this patient stable or not? At the end of your assessment, you want to know, is this patient stable or not? So we begin with A, airway. So you assess the airway. And for those who work in clinical environments, clinical practice, you know that there's something small that we use to help us not forget anything, and that is we look, listen, and feel. So for the airway, we look, we listen, and we feel. So we talk to the patient. Can the patient speak? If the patient can speak, then that's good. We know that our airway isn't in immediate danger, just like the case presentation we had. And then you move on. If the patient can't speak, unfortunately, we are hoping the patient reaches you when they can speak, but if they get to you when they can't speak or respond, in that case, you will have to do a chin lift, head tilt, and start the CPR protocols. But in case they can't speak, you continue with the assessment. Do you hear abnormal sounds? If the patient happened to be semi-conscious, let's say, and they still have vomitus or blood in their oral cavity, then you must suction and clear that airway. And if there is no chance of trauma involved, you can consider putting the patient in a recovery position here. But after the airway, when you've made sure that your airway isn't in immediate danger, then you move on to B, which is breathing. And in breathing, we are still looking at this patient as someone who's possibly lost intravascular volume. So you still look, listen, and feel. So you look at the respiratory rate. Is the patient breathing fast? A respiratory rate in adults of more than 20, we know that's tachypneic. So that's a sign that the patient is unstable, probably. Sounds. Then we check the oxygen saturations because we want to know, is this patient hypoxic? We are losing blood, we are losing oxygen carrying capacity, we are losing blood. So we need to know, is the patient hypoxic? Immediate interventions where necessary. So if the patient is toxic, you give oxygen. You move on to if the patient is breathing very slowly, like I said, if unfortunately this patient presents already at the point where they are hardly breathing or breathing very slowly, you start valve mask ventilation and you follow the CPR protocols. So to note here is that pediatric vitals vary with age. So you also need to bear this in mind. For pediatric patients, we are looking for a respiratory rate of more than 40 for a child of 1 to 5 years. We're looking at a respiratory rate of more than 50 for a child between 1 month and 1 year. And for neonates, we are looking at a respiratory rate of more than 60. So when you make sure that you've sorted the immediate problems in breathing, then you move on to C, circulation. And this is important for us in a patient who's bleeding, because remember, we are bleeding, so we are at risk of poor perfusion to the vital organs. And we know that when we have poor perfusion of the vital organs, this is where the problem is going to come from. This is where organ failure is going to come from. So we need to assess circulation really well in these patients. So we start looking for signs of poor perfusion right from the extremities, and then other signs to do with the organs. So we look for cool, moist extremities, cup refill of more than 3 seconds, indicates that the patient is not hemodynamic and stable. A tachycardia of more than 100 beats per minute. Hypotension, systolic BP less than 90, diastolic BP less than 90. That shows that the patient is not. But also to note here is that different people have their different baseline BPs, so you have to bear that in mind. A person who's usually hypertensive may present with what seemingly looks like a normal BP, but you need to know that it might be hypotensive for that patient. So it is worth noting that orthostatic hypotension is also one of the signs of intravascular loss. So if a patient gets a drop in their BP of about 10 to 12 from sitting to standing position, even if you've not yet reached your limits of 90/60, you know that you have a volume problem here. So you continue part of a circulation assessment. Also, you look at urine output because this is an indication of kidney perfusion. So you look for urine output of less than 5 mL per kilogram per hour. We know in adults is on the low side. For pediatrics, they have different values. For a neonate, we know that around 750 mL in 24 hours for a neonate is the normal. So below that, you may get suspicious. For an older child, 1 to 2 years, maybe 1 liter in 24 hours is normal. So below that, you will suspect that there is a problem with kidney perfusion. And in older children, above 5 to 10 years, it's about 1.5 liters 24 hours. So you must remember the pediatric vitals as well. So after assessing circulation, at this point, of course, you must intervene immediately if there's any sign of shock. If we have a tachycardia, we have hypotension, or we have a cup refill, even a cup refill, only a cup refill of less than 3 seconds in a child, for instance, you have to intervene. And just like in our case, you intervene by inserting 2 large bore IV cannulae. Immediately, you take off a sample from grouping and cross-matching, and then you give a fluid bolus, just like in our case. Presentation for adults at 20 mL per kg and kids at 10 mL per kg. And after that, you do a reassessment and then move on to blood products. So after stabilizing your circulation, then you move on to D, which is disability. And still, we are continuing with our signs of poor perfusion. Poor perfusion to the brain is going to present with an altered mental state, confusion, lethargy. So it's important that you check, you note the patient's GCS. If a patient is just confused, that's a GCS of maybe even 14. It's still significant in a patient who's bleeding. As long as they're confused or lethargic, that could be a sign of reduced perfusion to the brain. In pediatrics, you can use the ABPU score to assess their level of consciousness. And then, if they are not fully conscious, you check blood glucose levels just as a basic test. This one is a basic test for any patient that presents with an altered mental state. And also you can place the patient in a recovery position. If there was no history of trauma and you're not worried about your cervical spine, you can place the patient in a recovery position. So after noting the disability, noting the neurological status of the patient, we move on to E, which is exposure. And here we would check for external bleeding, but we are dealing with an internal bleed here. So you could do a rectal exam just to make sure that you don't have a massive GI bleed where you're bleeding all over upper GI, lower GI. And then you have to cover the patient to prevent hypothermia because we are losing intravascular volume in this patient and not the temperature. So after going through A, B, C, D, E and intervening for the immediate interventions, then we know that we move on to take a very pointed history, straight to the point history. And I'm sure we're all aware with this mnemonic sample history, where we look at the symptoms, allergies, medications, past medical history, last meal, and events leading to presentation. So that was done in our case presentation. It's a way to quickly get all your crucial history on board. So in the symptoms, we are looking at the significant symptoms for a patient with upper GI bleed. We have hematemesis, which is vomitus with bright red blood in it, or coffee ground vomitus. There may be history of hematochezia, which is bright red blood per rectum, or history of melena stool. This is usually dark tarry stool. So there may also be history of syncope, weight loss to point you towards malignancies, and also change in bowel habits to point you towards maybe the point you towards the other causes of GI bleed. So this echo session is focused on the upper GI bleed and variceal bleeding, because it's one of the causes with a great potential for mortality. However, we know that there are other causes which you can check for in patients. Important you quickly ask about NSAIDs. We know that NSAIDs is a common cause of peptic ulcer disease, which is a common cause of upper GI bleeds. We ask about anticoagulant therapy in case the patient is on anticoagulants, and that's what triggered their bleed. We look at the past medical history. Here we're looking for history of PUD, malignancy. You could have a malignancy or esophageal malignancy, gastric malignancies, duodenal malignancies. We could have a history of diverticulosis or bleeding disorders. So you look in our history, in our quick pointed history, we're looking for only those things that could produce a sudden bleed in this patient. And after we've taken our quick history, then we'll move on to a more thorough assessment, system by system assessment. This one I've not put it in because it is more of a detailed assessment, both system by system. But we move on to investigate the patient because we have a bleeding patient. So we move on to investigations. And as we are investigating the patient, once again, we are concerned about poor perfusion, condition, and then we're also thinking about any underlying pathology that this patient may have that made them bleed. So when you think about poor perfusion, you think about all your organs through and through. You look at the brain, you look at the kidneys, the liver, and you investigate all those organs. So, well, first we would need a complete blood count because we want to see how our HB looks like. We have a bleeding patient. We want to know whether our HB is within a safe range. And an HB, generally an HB of less than 7 in an adult is not good, would require transfusion. We are concerned about platelets because we are also bleeding out platelets. So platelets of less than 50,000 would need us to consider transfusing platelets. And in this patient who is bleeding, we need a coagulation screen as well with a prothrombin time and INR. We need to look at our kidney perfusion and we do renal function tests to assess how our kidney is doing in all this bleeding. So we have to note any decrease in glomerular filtration rate, any increase in BUN. We look at our liver function tests, which are very important in case we are suspecting variceal bleeding. We know that variceal bleeding basically comes as a result of portal hypertension, which comes usually from liver cirrhosis. So we need to look at the liver enzymes, ALT, AST. We need to look at the liver, the functions of the liver, the metabolic functions of the liver. We look at albumin, and we also look at, we can look at the heart as well. The heart can also be affected by perfusion, so we need to do an ECG. We can do an ultrasound both to assess the liver the liver status, liver anatomy, and also it can be done in the emergency department to assess volume status of the patient. So if you have a collapsed IVC or a hyperdynamic left ventricle, those are signs to you that the patient is hemodynamically unstable. It's a very useful sign in the ED when you're trying to assess a patient's volume status. And lastly, but most importantly, a patient who presents with an upper GI bleed is going to need endoscopy, especially if they have an ongoing bleed, if they have a hemodynamic compromise, or they are severely anemic. Endoscopy is indicated here, and it should be done as soon as possible. Also, like I said, this has we're focusing on upper GI bleed, but in case we have a lower GI bleed, there are further investigations. You can do a colonoscopy versus an endoscopy. You can do an angiogram, CT angiogram can also be done. If you are fortunate to have a patient who is quite stable and the CT is available and they can afford it, then you can go ahead and do a CT angiogram first before to assess the bleeding. But otherwise, these are the main investigations in the emergency setting when you have a patient with a GI bleed. So mainly that was mainly what I had for the assessment and investigation of a patient. Assessment is always A, B, C, D, E. Yes, so thank you for listening. I hope it refreshed your memory on this exam that we all know this exam, but at least I hope it refreshed your memory. Thank you.
Thank you so much. That has been Dr. Kamara, who has given us a very, very nice presentation on assessment and investigation of a patient with GI. Dear members, please, you have 2 minutes. Give us any question or any inquiry. Anything that you have not been sure of, you can please ask so that you're clarified. Meanwhile, doctor, there was a question earlier on. Someone would like to know the endoscopy findings and about the esophageal bleeding and how it can be graded. You can raise up your hand if you have any question or type in the chat. Someone else is asking for the differential diagnosis and referred pain, which are associated by the upper GI bleed. Thank you. You're going to be answered. Any other question before we move to the next program? Okay, I think people are really satisfied with that elaborate presentation. So let's move to the next program, which is nursing a patient with GI bleeding. That is going to be handled by Ms. Hamida. Please, Ms. Hamida, you're most welcome. Unmute and give us your presentation. Thank you.
You're welcome. Good afternoon, members, once again. I'm sorry, I didn't prepare slides. I actually wrote some notes, like some points. So I don't know if people would be really needing slides, I can prepare them. And as I see, they've told them they're going to put them on the emails. That is, if they really need them. But let's try to maintain time by looking at the nursing care for active bleeding of esophageal varices or for GI bleeding. And basically the aim here is to assist in controlling bleeding and preventing shock or other complications that may arise. Dr. Kamara has talked about the assessment. As nurses, we are also told to keep assessing our patients. There is no way you're going to intervene or nurse a patient when you've not assessed about their presenting complaints and how they are presenting. That is how we would be able to form a nursing care plan. The first thing, we perform an ongoing assessment. Remember, as we keep assessing our patient throughout. So as we keep nursing, providing nursing care, we provide the assessment throughout. Then Dr. Kamara talked about the ABCD, and here we ensure I have a patent airway. Remember, this patient is vomiting. If not vomiting, you may also still assess to see if you have the airway that is clear. And if you really see the patient is vomiting or there is the air is not clear, first they talked about for the position of the recovery, or you can also use the semi-frozen position to avoid aspiration. Then you can suction if necessary. If you see the vomitus is a lot, and in case the patient is semi-cautious or uncautious, you can opt for suctioning. Or if the exudate is a lot or the vomitus is a lot, you can choose to suction. Then we have to look at our vital signs. Remember, we are looking at the BP. We may have a risk of hypertension, so we have to look at our BP. We have to look at the heart rate. We have to look at the saturation, that is the SpO2. We also have to look at the AVPU, those scales. So we have to look at those, and sometimes they consider pain, the fifth vital sign. So you also have to look at pain, but you have to look at the other ones closely, the BP, and you keep intervening. Basically, if you have to observe for signs of hypovolemic shock, we are losing fluids through vomiting, and we are losing blood. So you have to look for signs of shock, and Dr. Kamara has actually given you all the signs of shock. And in this case, you have to establish IV line on both hands, or you have to establish 2 IV lines in case of emergencies, because you know you will have to give fluids and other medications. So in cases of emergencies, or in this case, it is very best to have 2 IV lines with large bore cannulas, that is size 18 in an adult. In children, you can go as gauge 24 because it's learned for children, and sometimes gauge 22. But you make sure you have at least 2 to manage emergencies in case they arise. We have administration of the drugs that have been prescribed. So as nurses, we make sure that all the drugs that have been prescribed, like the IV fluids, blood transfusion, the vasopressins that may come in. Actually, Dr. Orit is going to talk about the medical management, and we make sure that all those drugs are actually given and in the timely intervention. Then we have blood samples. We talk about blood for samples. First, remember we talked about HB that normally falls, or that is below the recommended value, that is around 7. So you may need blood for CBC. There is grouping and X matching. We've been, this patient, in case the patient has been vomiting, we might actually look at the electrolytes. Basically, we have to measure and record input and output. And in a patient that is conscious, you can always record the input. Those are the fluids, the orals. Then the output, you may not consider a catheter. That is, if you have jars that have those, I don't know if you people have come across the jars that have those measures, but they're there for a patient who is conscious. But for a patient who is semi-conscious, or the patient who is in shock, you would really need a catheter so that you critically look at your input and your output. Then we have to do reassurance throughout and moral support to the family. That is family and the patient. As nurses, in the nursing management, this is one of the basics we need to do, because it is scary for a person to wake up and they're vomiting blood. So they are their vomiters has blood. So their relatives, themselves, they're scared about the condition. So the continuing reassurance is one of the things we do. Basically, we have to also do the education, the teachings. We have to teach these people what they are going to do, what is going on, and what we are doing, as they give them the basics of what they need to understand. Basically, we need to, there is the care we can give during the endoscopic procedure. That is when we are assisting the physician or the person going to do the endoscopy. In the investigations, they talked about endoscopy. Sometimes it can be used for management, or it can be used as an investigation. So you as a nurse, first thing, you ensure that your patient has a patent airway before the procedure. And so you make sure you assess the level of consciousness, then you prepare for the procedure. Then you get the informed consent from the patient. You make sure there is an informed consent that has been sought before the procedure, then explaining the complications that the patient might get, like the chest discomfort, the nausea, the dysphagia throughout the procedure. And you advise the patient to maintain the nil per os as desired, like when the physician desires for the nil per os to be for 6 hours or 4 hours or what, those are, you make sure it is also. So basically that is when our nursing interventions when we are doing the endoscopy. And then we have the nursing care that we can do for secondary bleeding. I saw in the case presentation, doctor was talking about the patient was coming in the second time with the bleeding. And so what we can do is educate the patient about the regular follow-up. Remember, the conditions that were mentioned were, so some of them are like liver cirrhosis, the causes. So sometimes you tell the patient to come for a follow-up so that we prevent a secondary bleed. Then we advise the patient to avoid the risks. Like NSAIDs, we all know what NSAIDs do. Irritating foods, those are spiced foods, those can also lead to a bleed. Taking alcohol, smoking, we advise the patient against that. And then we teach them to cope with the disease. Like, it's more of counseling. Some diseases like liver cirrhosis, some of the causes of the bleeding are chronic. So we must teach these patients and ensure they actually learn how to live with the disease. And then basically there are those a nursing care plan which you can always come up with according to the concerns you have. There are those nursing diagnoses like acute pain, deficiency or deficit fluid volume, those ones that you can make up and put them in the nursing care plan. Then we actually have to make sure thoroughly, as we are managing this patient, that all the things we do are aimed at prolonging their lives and preventing complications. So when we are dealing with with the patients, we need to make sure whatever we are doing is preventing any complications or more bleeding, or we actually controlling bleeding. Then the other thing that there sometimes we are recommended to maintain nil per hour in these patients in the first 24 hours. So we also have to ensure that, but that would also depend on the extent of the damage or the bleed we are dealing with. And within hours, they are actually okay or better, but there are those that would come in a state that is very bad. So thank you very much. I don't know if there are any questions.
Mrs. Hamida, for such a very wonderful nursing care presentation of a patient with GI bleeding. Dear members, please have 2 minutes to text in any questions that you have in the nursing part, or raise up your hand so that you're picked to ask your questions. Yes, please, Benjamin.
Yes, thank you so much. This is Benjamin from Ngora Medical Hospital. I wanted to find out in the nursing management. We say that we don't give, we give nil per hours. So I wanted to find out, is there an indication of ice pack in preventing bleeding in esophageal varices?
Okay, thank you so much, Benjamin. Please, Sister Amina, you can attend to him. Thank you.
He's asking about the ice pack.
Yes, ice pack.
I really don't think we really need the ice pack unless all otherwise.
Okay.
I actually am seeing a question here about the suctioning. But when we are suctioning, we are not actually going deep into someone's esophagus. You suction what you're seeing, and that is what you're seeing in the mouth.
Okay, thank you so much.
So you're not going to suction so deep.
Okay, thank you so much, Sister Amida. I would like to give Dr. Kamara to say something about the ice packs. Thank you, Doctor. You're welcome.
Actually, there was another question forwarded about the endoscopy findings and grading of the varices, which I will pass on to Dr. Orit because he has it better in the ice pack.
Thank you, Dr. Daniel. You're most welcome to attend to that question.
Okay, thank you very much, Dr. Kamara and everyone in the house for the question. So just to answer the person who had earlier on asked about endoscopic grading of esophageal varices. So we have 2 classification criteria. Here I'm focusing on varices because later on I'll take you through bleeding peptic ulcer disease classification on endoscopy. But when it comes to esophageal varices, we have the Baveno 6 classification, as well as the Sarin classification. Now in Baveno 6 classification, they simply look at the sizes of the varices. In that grade 1 looks at small and straight varices, while grade 2 looks at enlarged and tortuous varices, while grade 3 looks at large and coil-shaped varices. That is on endoscopy. Then when you look at the sarin classification, still we have type 1, type 2, then something called an isolated gastric varice. And in type 1, according to the sarin classification, the varices are of the size of 2 to 3 centimeters below the gastroesophageal junction, and also there's continuity into the varices, okay? As in, it's 2 to 3 below the gastroesophageal junction. Now in type 2, just pay attention to this. In type 2, the varices are majorly in the cardia, the fundus of the stomach, then they also extend to involve the gastroesophageal junction. So a distinction between the two is that in type 1, we saw that they are majorly in the gastroesophageal junction, while in type 2, we have some of the varices appearing in the cardia, the fundus, with an extension into the gastroesophageal junction. Then still in sarin also looks at isolated gastric varices. And in this case, we shall have the varices located in the gastric, the gastrium and the fundus, and the cardia, but nothing extending into the esophageal junction, okay? So that is majorly the endoscopic classification of the varices. You base it on the two classification, Bapeno, as well as the sarin. Then as per the role of the ice packs in esophageal varices, I take you still back in understanding. You remember the slide that I presented when we looked at the different causes, and you remember I clearly told you it's about you understanding the portal venous pressures as well as the portal hypertension. And at the end of it all, what we're simply looking at is a buildup of the pressures that is going to have a backflow into the small varices lining the gastroesophageal junction. And these varices are thin-walled. And when the pressures build up, definitely they're going to rupture. So ice packs have no role in this. The drugs that have a role in this game in stopping the bleeding are majorly the drugs like telepressin. Later on, when we look at management, you'll see drugs like telepressin, you'll see drugs like octreotide or somatostatin. And in each of these, their mechanism of action is simply looking at them binding onto the V1 receptors located in the splanchnic circulation, and are able to reduce the pressures. So the key point is here is understanding one, how do the varices arise? Portal pressures, portal hypertension. How do I stop the portal pressures and portal hypertension? I need a drug that is going to bind onto a receptor and reduce either the portal pressures or reduce the blood flow into the varices. And in this case, we're reducing the pressures. Otherwise, ice has no role. It's more like a placebo. Then also later on, when you look at drugs like propranolol, because when you look at management, you're going to look at drugs like propranolol. Propranolol is a non-selective beta blocker. And we know that we have beta receptors in the splanchnic circulation as well as the cardia. And what propranolol simply does here is to act on the beta blockers located in the splanchnic circulation. And they're going to reduce the portal flow and the portal systematic circulation pressures. And in this case, the patient will be prevented from getting ruptured esophageal varices. So ice, more of a placebo than anything. Thank you, Anova.
Oh, thank you so much, Dr. Orit Daniel. He has given us into details of the two questions that were asked. Members, let's please go to the next thing on the agenda, which is the management of bleeding, esophageal varices. And this is going to be handled by Dr. Orit Daniel. Thank you, Doctor, you're most welcome.
Okay, thank you very much, still everyone on call and all my presenters in the house. So when we look at management of esophageal varices, we're going to look at one, okay, get down. Just go to manage straight. Okay, sorry for the hiccup, but the slide is coming through. The last slide, yeah? Just go to management. Okay, management there. Thank you very much. So when we look at management of esophageal varices, just like in any public health approach, it's very key that we have a primary prevention approach as well as later on a secondary prevention approach. Because time and time again, you're going to have patients coming in and having liver cirrhosis. And of course, your goal as a clinician, a medical doctor, nurse, is to see to it that later on, as you talk to these patients with a liver cirrhosis, you don't want them getting into have variceal bleed, because treating variceal bleeds, believe me, is not an easy thing. One, it's a very expensive thing. Then two, it's a very big stress factor to the patient. And three, it actually has a very high mortality. So key in the management aspect is one, to look at primary prevention. And in primary prevention, we're simply looking at routine screening by endoscopy of all patients with liver cirrhosis. So the key point here is that once a patient has been diagnosed with liver cirrhosis, key in his discharge or in his outpatient assessment is to always tell them to always have a routine screening by endoscopy to be able to detect any varices that are developing. So once the varices that are at increased risk of bleeding are identified, then prophylaxis can either be achieved through non-selective beta blockade or by variceal band ligation. And in individuals with compensated liver cirrhosis and absence of varices should undergo screening at least 2 to 3 times per year. Okay, so that was just primary prevention. In this case, the patient has liver cirrhosis. Of course, we know that is a risk factor already for the patient developing variceal bleeds, but has not yet vomited blood. So you do not want this person to progress to a situation whereby the varices grow in size and later on rupture. So that's why we're first looking at the primary prevention aspect, okay? Then what if the patient progresses? Next slide. Okay, next slide. So when the patient progresses and gets an active variceal bleed, like for the case that we looked in case 1 that was presented by Dr. Nelson, we clearly saw that that patient had a risk factor of liver cirrhosis. And of course, patient had not taken this serious, had never gotten any counseling about routine screening for endoscopy. So this is a patient who later on developed big varices, and later on the varices ruptured and patient gets admitted to the ward with active bleeding. Now, 3 key things that have been emphasized by all the GI professors. The first key thing is resuscitate. I'll later on expound on what we mean by resuscitation. And the second thing is find cause, and the third thing is treat the cause. Key in management of a patient who presents to the emergency unit in all your regional referral hospitals, district hospitals, health centers, or even in the clinics, is to put into consideration that first aspect that looks at resuscitation. And to make resuscitation key to you is that in resuscitation, we simply look at 6 things, which has been alluded to earlier on by Dr. Kamara, the sister who's just presented, as well as Dr. Nelson. So the first thing in resuscitation, after looking at the ABC protocol, is insert a large bore cannula. And when we look at cannulae, large bore cannula in this case is gauge 18, gauge 16, the gray. If you can't get the gray, then do a green, that is gauge 16. On several occasions, we've seen patients coming with active bleeding and they're putting on them blue cannulas. Of course, you know that is a very small gauge. In this patient, you're trying to fight the patient from getting shock. So you use a small caliber cannula, you know what that is going to happen. So the first thing in resuscitation, large bore cannulae, size 16, size 18, in case you don't have size 16. And we all know as you pass the cannula, of course, you'll be able to get blood for emergency investigations. And the emergency investigations that you can do at that point of time is the CBC, as well as blood for grouping and cross-matching. Other emergency investigations would be the likes of prothrombin time, which is not done in most of our facilities. But if you're in a good facility, those are some of the emergency tests that you're going to do. Then 3, on the resuscitation protocol is first run IV fluids as you wait for blood to come. Because remember, you've gotten this person's blood, sent it for emergency investigation, grouping and cross-matching. So in that process, as you're waiting for blood to get back, at least run some IV fluids. It's recommended at least run 1 liter to 2 liters in the first 3 hours as you wait for blood. So we expect that as you're running the IV fluids, by that time blood would have been brought to the emergency room. Then you can run whole blood. And as you're running whole blood, then the next step is giving the patient pharmacological medication. Now, if you're treating a variceal cause of a GI bleed, the drug of choice is telepressin, IV telepressin. You can give it at 2 milligrams as a bolus. Then later on 1 milligram 4 hourly for the next 72 hours. Then last on the point of resuscitation is monitoring. Monitoring is so key in these patients. And what you're simply monitoring for has already been alluded to, but I'm going to still mention it, is look at the vitals like the pulse rates, look at the blood pressure, the urine output, the mentation, and there's something that we call a venous harm. Now, in most cases, when these patients come and they've vomited blood, you find, because they're in a state of hemodynamic instability, you'll find they have a pulse rate of greater than 100. We don't want that pulse rate of greater than 100. We want that patient to always have a pulse rate of less than 100. A blood pressure, in most cases, they'll have a blood pressure of less than 90s. Your role as a doctor in monitoring to see that the patient at least has a blood pressure of greater than 100. A urine output at least 500 mils. Then the patient's mentation, and then finally something that we call a venous harm. A venous harm is more practically done, so I can't demonstrate it in this presentation. But key in that resuscitation is monitoring the patient, the 6 things that I've just talked about. Now, the mistake that majority of clinicians make is that they think that after you've added such a patient blood, IV fluids, and given them telepressin, you think the patient is resuscitated. But whenever you ask the question that is your patient resuscitated, how do you tell the patient is resuscitated? It's just by looking at the vitals. So I strictly emphasize your vitals are key. If the vitals do not meet the recommended ranges, just know your patient is not resuscitated, and find a way of either adding them more blood, giving them the telepressin dose, just to pull them out of the hemodynamic instability that they've come. Because your major role in this first point is to stabilize that patient. Because you can't send this patient for endoscopy when they're not yet stable. So the key thing is in resuscitation, stabilize the patient. Once the patient is stable, then you can refer the patient for an endoscopy, okay? So in the second thing that we talk about there, finding the cause is simply sending the patient for endoscopy, and in most cases that is after you've stabilized the patient. And in endoscopy, the endoscopist will be able to tell you the class. Remember earlier on I told you about the Baveno and Sarin classification. The endoscopist will clearly tell you that, okay, this patient has this type of varice, and my intervention is going to be this. So after identifying the cause, the next thing is, if now you've identified the varice, that this patient actually has a bleeding varice, the next step in management, slideshow. It's gone off. Okay, yes, sorry. Okay, so the next step after identifying cause is now to treat the cause. The endoscopist has passed the scope into the patient's GI, has been able to identify a bleeding varice. The next step is something that we call a band ligation. If he can't do a band ligation, he can do something called a sclerotherapy. Okay. Okay, just move to the next slide. I show them what band ligation is. Okay, so in band ligation, what it simply means is that it's going to identify the varice. A varice is simply like a bulge inside the stomach, as you know, at the gastroesophageal junction. And it's majorly that bulge that ruptures and spurts out blood. So when you look at the slide that has been projected, I want you to focus on the diagram of the liver and the extreme 2 vessel slide. So one of them says band ligation. And when you look at that critically, you really see that there's a bulge there that looks like a P-shaped bulge. So in band ligation, what the endoscopy does is that he pushes the scope in there and is able to tie up that varice. When he ties up that varice, then we're able to control the bleeding. In case he can't do that, there's something that we call sclerotherapy. He's still going to pass the scope, then inject a sclerosing agent into the bleeding varice, and we know sclerosing agents are simply going to seal off the bleed, okay? So those are the recommended treatment mechanisms for a patient who comes in variceal bleeding. However, when the two fail, as in band ligation or sclerotherapy, and the patient is continuously bleeding, there's something that we call a TIPS, okay? TIPS is more like a shunt. So when you look at that diagram, if I wish you could, okay, no, this other side. Okay, you see that there's a stent there, eh? Just point onto that stent. So a TIPS is simply like a shunt. You just shunt off blood. so that you direct it straight to the systemic circulation, so that you don't have pressures building up and causing a bleeding varice. Okay? Then still, if you're in a good setting and the two have failed, there's something that they call a balloon tamponade. Sorry, I didn't have a specific slide on this, but there's something that they call a balloon tamponade. They pass it into the gastroesophageal junction, then it creates like a pressure on the blood vessels, just like how you tie a band onto someone who comes with, let me say, a bleeding arm and you want to control bleeding. So what a balloon tamponade does is simply you pass the balloon so that it acts like it's creating pressure onto both sides of the lumen, and this way it's going to occlude the pressures and be able to control bleeding. Okay? But key to note is that in your patients, one is resuscitate, identify the cause. Once the cause has been identified, then treat the cause. In treating the cause, the definite treatment is the band ligation, sclerotherapy. If you're in a good setting and the two have failed, then you can do something that we call a TIPS. Now, to look at the slide on the extreme left, you see the vasoconstrictors, and these are the pharmacological drugs that I earlier on talked about. We have IV octreotide, and the dosage recommended is at about 50 micrograms as a bolus. Then later on, we're going to give them 50 micrograms per hour as an infusion for 2 to 5 days. In case you don't have octreotide, which is rare actually, in our setting, what is common is IV telepressin, 2 milligrams every 4 hours. Then after, you're going to do 2 for the next 48 hours. And then antibiotic therapy is majorly to prevent sepsis, because most of these patients are predisposed to getting sepsis. So you can use IV ceftriaxone in case the patient is a child-Q classification, B and C, or you can choose to use ciprofloxacin in case you do a child-Q classification in this patient and does not belong to child-Q, B and C. Then the endoscopic therapy that I just alluded to, banding is preferred, although you can use sclerotherapy. Then the salvage therapy is a balloon tamponade, just in case you're in a good setting that can do all the things. So key to note is that whenever you have a patient, like the patient that was presented earlier on, the patient had been advised to do an endoscopy and later on do the banding, but the patient, of course, was constrained by financial reasons. But if the patient can afford, please encourage them to always seek for endoscopic services, then they undergo this band ligation or sclerotherapy, because it will save them a lot. Why I say this is that they never know when the varices rupture and throw them into an upper GI bleed. And we know upper GI bleed, in most cases, the mortality rate for the patients that have really seen, both at Kiruddu and Soroti, we have a majority of them passing on because they come in a little late, and when you tell them about banding, they take it lightly, and yet, in actual sense, this could have saved them. So thank you very much. I want to end here and await any questions that may arise from the presentation of management of esophageal varices. Now, before I really sign out on this, we also have bleeding PUDs as a common cause of non-esophageal varices. And still looking at how we manage bleeding PUDs. Like you remember earlier on when we were making a presentation of the different causes, we said we have variceal versus non-variceal. How we manage variceal is different from how we manage non-variceal causes. So if we're looking at non-variceal causes, and majority are caused by bleeding peptic ulcer disease, at endoscopy, when you pass a scope, you will have to classify the bleeding PUDs using something that we call a Forest classification. It's majorly done on endoscopy. So in Forest classification, we have a Forest 1 classification, Forest 2, and Forest 3. Now the plan of management is also dependent on Forest 1, Forest 2, and Forest 3. In case on endoscopy, the patient has Forest 1, it's majorly an active bleed. So the plan of management in that case is in most cases something called a sclerotherapy. If I told the patient is at class 2 and class 3, basic management will majorly be to use a PPI. So that's why we emphasize always as a clinician, have it in mind. Am I dealing with a variceal cause of an upper GI bleeding, or am I dealing with a non-variceal cause? Because later on, when it comes to the plan of management, they are a little different. However, much as there's a difference, the first stands in resuscitation, it's almost the same. But when it comes to the definite treatment, that's where the difference comes in. So thank you and over, and I await any questions that may arise. Thank you.
Okay, thank you so much, Dr. Orit Daniel. That has been so elaborative. Here in the chat, someone would like to know the rational use of propranolol and somatostatin.
The first question.
Yeah, that's the first question. And the second question, someone is asking, is there a need of surgery?
Surgery, okay. Okay, thank you very much. For the first person who asked the question, octreotides, what octreotides do is that they are vasoconstrictor agents that decrease inflow of blood to the portal splanchnic circulation. And what they simply do is that they constrict the splanchnic arterioles. And once they constrict the splanchnic arterioles, then they're going to reduce on the pressures that build up there. And they're going to prevent the patient from rupturing their esophageal varices. And that's why they're recommended. However, in our setting, octreotide is really rarely used because what is common in our setting is majorly the telepressin. That's why in most places that you go to, you'll find there'll be telepressin and not an octreotide. Now, for the case of propranolol, yes, propranolol, like I earlier on alluded to, it's a non-selective beta blocker. And when you look at beta blockers, one thing that you must understand is that where the beta receptors, where they work. So we have a B1 and a B2. Beta 1s are majorly in the heart, and beta 2s, some are found in the splanchnic circulation, others are found in the bronchial tree. So what beta blockers do is simply to reduce the portal pressures, and once they reduce the portal pressures, they're going to reduce on the portal hypertension in this patient, and the patient won't get into a bleeding esophageal varice. However, when you're using propranolol, it's very key that you titrate that dose to achieve a pulse rate of about 55. If the patient's blood pressure is less than 90, do not use propranolol because it will shut down the pressures. They'll drop. So that is key about propranolol as well as telepressin.
Okay.
Thank you, and over.
Thank you so much, Doctor. Someone also would like to know how we can first achieve the hemostasis and if the use of tranexamic acid is required.
Okay, that's a question that has arisen in many of the forums that we've had concerning upper GI bleeding. Now, I still take you back into understanding principles of how variceal bleedings occur. Like I earlier on alluded, portal pressures, portal hypertension. When you look at the mechanism of action of tranexamic acid, it majorly exerts antifibrinolytic effects by blocking lysine binding sites at the plasminogen molecules. And this is not the mechanism of action that brings about variceal bleeds. So tranexamic acid, still, like I said, placebo, like ice packs. But you'll find a majority of people will use it. But when you get down to first principles, really, it's not going to do any role in stopping the portal pressures. Because the key thing about variceal bleeding is stop the portal pressures, reduce the portal hypertension, so that the varices do not rupture. That is the key thing. Okay, thank you.
Okay, thank you so much, Doctor. Someone would like to know if there is need for prophylaxis management in the hepatic encephalopathy.
Well, that is key because later on when you look at, because by the time a patient has liver cirrhosis and gets into this complication of variceal bleed, definitely they're being exposed to other complications that come as a result of liver cirrhosis, and that is hepatic encephalopathy. Now, we all know that what worsens, some of the things that worsen hepatic encephalopathy or will bring about hepatic encephalopathy are GI bleedings. So the earlier we prevent this, the better. So it's very nice to give them a prophylaxis, but as you're giving a prophylaxis, you won't give them 30 mils of lactulose, but you'll give them about 10 mils of lactulose, as opposed to 30 mils when you're treating overt hepatic encephalopathy. So yes, right, we can do a prophylaxis for HE, looking at the mere fact that it's one of the predisposing factors for patient. A GI bleed is one of the predisposing factors that can worsen hepatic encephalopathy in a patient.
Okay, thank you so much, Doctor. Members, if you've been really keen, most of the questions have been answered in the management, and I hope I have not left anyone out with a burning question or any query. Meanwhile, there is a link already in the chat. Please click on the link and have yourself registered. And we are going to move to the next session where we shall have the post-test. The link is also going to be shared. All right, so please, you can keep any other question if you still have. Please raise up your hand or text in the chat as you click on the post-test link so that you attend to the questions which are there. So someone would like to know, how about if the patient is having a coexisting condition, which is congestive heart failure, and how would you go about it in the management, especially the pharmacology?
Okay, so in a patient with congestive cardiac failure, it also depends on, they come, okay, maybe let me first ask the person, does the patient come in acute decompensation or is the usual outpatient congestive cardiac failure? Okay, but either way, because we may not be able to get the person online. But when you look at management of congestive cardiac failure, of course, you have to categorize two things: drugs with a symptomatic benefit, drugs with a mortality benefit versus drugs without a mortality benefit. So that's why I clearly wanted to understand at what state did this patient with congestive cardiac failure come in. If at all they came in acute decompensation, of course, the key drugs at that particular moment are drugs that are going to relieve symptoms, and that's where you have drugs like the Lasix, the morphines, and the nitroglycerins. But however, if you're managing a stable patient with congestive cardiac failure, and you're putting them on drugs with a mortality benefit, that's where now your drug like a beta blocker comes into play, or AC inhibitors or ARBs. Now, remember, we are looking at beta blockade in upper GI bleeding, and we're talking about using a non-selective beta blocker, and that's where the drug like propranolol came into play. While in majority of patients who come with cardiac failure, congestive cardiac failure, the beta blocker of choice is a B1 selective beta blocker, Carveddio. But studies that have been done have shown that much as we have Carveddio hitting majorly a B1, it also has some very, very limited effects affecting the B2. So we can still do a beta blocker like Carveddio in these patients. So that I don't remember the name of the study, but it's one of those research studies that had been done trying to verify beta blockade in a patient with variceal bleed and has a underlying comorbidity of congestive cardiac failure. So Carveddio can still have a role to play in this case. Thank you.
Okay, thank you so much, Doctor. Someone is also asking about the PPT time. If it's found to be below, what are you going to do if it's low in this case?
PPT?
Yeah,
maybe.
The prothrombin time.
Okay, the prothrombin time. Let me just put it.
Meanwhile, the link is already shared for the post-test. Please click and answer the questions so that we know if you've learned or you've gained something that is going to help our patient out there.
Okay, so if the prothrombin time is found to be low, now remember, when you look at prothrombin time, simply you're looking at, okay, I'll just take you back into understanding the waterfall cascade. And when I say waterfall cascade, I'm simply looking at extrinsic factors versus intrinsic factors in the coagulation pathway. So prothrombin time simply looks at the coagulation factors. Now we all know that in a patient with, by the time a patient has liver cirrhosis, definitely factors 2, 7, 9, and 10 are also being affected because these are factors that are being made by the liver. So in case we have a low prothrombin time, it will be imperative that we give this patient a vitamin K. Because what vitamin K is simply going to do is that it's going to convert the inactive forms into the active forms of the clotting factor 2, 7, 9, and 10, and it's going to help us as well as stop the bleeding, but not controlling the blood pressures, okay? I mean the portal hypertension pressures. So thank you.
Okay, thank you so much, Doctor. Dear members, I'm not seeing any other new questions except the old ones which were already answered. There is someone, yes, Eric, you have questions? Please unmute and talk.
Okay, thank you so much for finally giving me the chance. I've been raising my hand, but fortunately all my concerns have been answered by the doctor and the sister. Dr. Daniel, I just want to know about blood transfusion. Clearly it is stated that below 7, deciliters you can transfuse, but does it worsen the variceal bleed if you transfuse the patient vis-a-vis doing endoscopic intervention? What's your comment on blood transfusion and worsening of the bleeding?
Thank you very much for that question. So the books will clearly tell you that when a patient comes and has variceal bleeding and you've done the CBC and the HB is less than 7, that's the target that you can use for transfusing. But you and me know that when a patient has just lost blood, just related to a trauma patient, let me say I've just gotten trauma. Of course, if you do my CBC, in most cases, you won't have a low HB immediately, you get. So the key thing, much as the books say that, at times, diseases don't, there's that statement where they say that diseases don't treat books. So if a patient comes and of course the HB is greater than 7, but you clearly know that this patient has vomited almost, let me say a bucket full of blood, chances are high that the immediate CBC that you're going to do will not show a below 7. But when you give it time, about an hour, 2 or 3 or 4, this patient's HB is definitely going to drop to this. So to salvage the patient and avoid the patient getting into shock, I'll really recommend, if possible, save this patient's life, give them blood if it's available, okay? Just give them that blood, otherwise you're going to defer and say, okay, the book said the patient didn't have an HB of 7, you're going to defer giving the patient blood, then 5 hours down the road or 4 hours down the road, the patient's HB starts dropping and you no longer have this blood, because you also know the dynamics of getting blood from the blood banks in a majority of hospitals. So if it's available, give the guy. You'll have saved this patient than trying to follow protocol of the books. Yet you clearly know that 4 hours down the road, that HB is actually going to drop. So to me, my recommendation would be giving the blood to save a life. Thank you and over.
Okay, thank you so much, Doctor. Is there any other question? I hope you are attending to the post-test. The link was shared. You have 2 more minutes to... Yes, Eric, you still have a hand up. Yes, Mr. Eric, could you please unmute and talk?
I'll tell the prognosis of these patients who come with who have been managed for varices.
Please come again. The network was off and we couldn't pick the first few statements that you made.
Well, okay, I'm asking if you put patient, I'm asking on the prognosis of the patient after putting him or her on treatment. Number 2, if there are other, I wanted to know also if there is an age limit or the age group which are actually predisposed or at risk factors for these diseases. Thank you.
Okay, thank you very much, Eric, for that question. So I wanted, because remember, when we looked at treatment, we had the pharmacological management versus the surgical management, the banding exactly. So I'm just wondering, which treatment are you looking out for a better prognosis? Okay, then 2, the age bracket, of course, it just depends on the risk factor that predisposes you into getting anything that is going to affect the liver, blood flow through the liver. So of course, a majority of the risk factors, okay, something that wasn't, okay, I think it was even said in the earlier presentation, a majority of the patients, when you're taking their history later on when this patient is stable, the risk factor that you're going to look at majorly, a majority of these patients could have taken alcohol, okay? Because alcohol is going to, when you take alcohol for a long period of time is a predisposing factor for you getting an alcoholic liver cirrhosis. You get alcoholic liver cirrhosis, you know the next thing, the complication setting. So looking at the age bracket now, this is something that I want to share with you. At what age do people start taking alcohol? Okay, so it gets back to that. Then the second thing, if we're looking at another risk factor, is something that we call schistosomiasis. Of course, in your history, you're going to ask this patient if either they have been fishing, living near lake shores, and of course that predisposes them into getting schistosoma mansoni. You know what schistosoma mansoni causes. In the long run, a patient is going to get liver periportal fibrosis. You get liver periportal fibrosis. You remember the diagram that I presented at first when we looked at the different causes. Once you get fibrosis, the next thing that you're going to have a build-up in portal hypertension, and you get varices. So age of fishing, age of living next to a SAM cuts across. It's not like alcohol, whereby we know particular people start drinking alcohol maybe when they're in their teenage. Although their cultures start taking alcohol as early as 8 years. So age is dependent on the risk factor that is predisposing the patient to getting a liver cirrhosis. Then also things like hepatitis. You've seen patients come with hepatitis. Like our patient clearly had hepatitis C. Hepatitis C, hepatitis B does not have an age bracket that it sets a caveat on. It affects all ages. So you have earlier hepatitis, you manifest into a cirrhosis, the next thing you're going to get a complication of a variceal bleed. Okay, then also we have congenital hepatic fibrosis that clearly happens in the younger child groups. And in that case, when they get that, portal hypertension builds up and still you're going to get varices as a complication. So looking at age, at what age that these things happen, it's just depending on the risk factor that you have and at what age you got predisposed to the risk factor. Because also the longer the duration that you live with the risk factor, the chance that you're going to progress into the chronic complications that come with a liver cirrhosis. Okay, hope I've answered you. Thank you.
Okay, thank you so much, Doctor. The last question I think I see which has not been responded to is someone want to know about the role that vitamin K plays in this case.
Okay, earlier on I talked about, you remember we talked about something called prothrombin time. And prothrombin time, of course, was just looking at your clotting factors. So the role that vitamin K has to play in this particular case is just to activate the inactive forms to be able to get the different clotting factors. But the clotting factors per se, like you all know, a clotting factor will just, let me say, at the point where the variceal bleeding is occurred, it will help form a clot. But remember that definite treatment is not about forming a clot at that particular point. As long as I continuously have pressures building up, the pressures build, it's just like the pressures will build up and flush out that clot. So really vitamin K has a very, very limited role in such patients. The only role it just has is that the mere fact that this patient has a compromised liver that cannot generate clotting factors, and once I have something rupturing, I continuously bleed and I can't form a clot to block off the ruptured vessel. But as long as the pressures continuously bleed, vitamin K will have a very, very limited role in helping out this patient. Thank you.
Thank you so much, Doctor, for such a wonderful response. Please, members, check on the polls or quizzes in order to access the post-test. There is also post-evaluation of the session, which has already been posted. Please ensure that you also click there and be able to evaluate us. Is there something that you think we can improve on for a better presentation in the next session after 2 weeks from now? You can give us your suggestions. So as you do that, I would like to appreciate everyone for today's session. It's really been great. I hope that every one of us has taken in something that is going to improve the life of our patients, our clients, and our family members. They may not be family members, but whoever will come in our hands as a nurse or as a physician, as a laboratory technician, will be able to play a very important role. Okay, so before we wind up this session, I would like to invite experts of today to give us a closing remarks of today's session. Thank you so much. Let me start with Dr. Kamara. Dr. Please, you're welcome to give us a closing remarks.
Thank you so much for having me. This has been a very enlightening session for me. And also I was honored to be part of this refresher course. Thank you.
Thank you so much, Dr. Kamara. Dr. Daniel, do you have something to tell us in the evaluation?
Okay, as a closing remark, okay, thank you very much, everyone who has participated in this session. My team seated here, Dr. Nelson and Soroti for presenting the case presentation, the SEED global staff, as well as everyone who tuned in. We're so grateful for you. And I'm very delighted to be part of this team. And my final closing remark take home, like I still emphasize, in my practice, I've seen GI bleed kill people. And like we said earlier on, when you receive such a patient, on top of looking at the ABCs that Dr. Kamara and Sister earlier on alluded to, put into consideration the aspect of resuscitation. Watch out for the sick things in resuscitation. And as a clinician and nurse, having it to always monitor this patient's vitals, because it's through the vitals that you're able to tell the patient is resuscitated or not. If you ignore the patient and think that resuscitation is based on how much blood you gave the patient or how much fluid you gave the patient, this patient may never come out of the unstable phase hemodynamic state that has been caused by variceal bleed. So put monitoring as a key aspect whenever you have these patients after implementing the resuscitation procedures. Once the vitals get back to the recommended values, then you can clearly say that I've pulled this patient out of a hemodynamic instability and encourage them to go for definitive treatment that involves endoscopic banding, ligation, sclerotherapy, and if they're in a good setting, still they'll do a balloon tamponade or a TIPS. Thank you and hope.
Thank you so much, Dr. Daniel. Dear members, may we also hear from our two experts who have been online, that is Dr. Nelson and Mrs. Hamida. Dr. Nelson, please, can we hear a closing remark from you?
Thank you so much, team, for the wonderful job done. Yeah, it's been really a beautiful moment. I've personally learned a lot. I'd like to thank you all for choosing me to be part of the day's team. Dr. Orit Daniel, I'm really very, very grateful for the always offered to us, teaching us bedside. You're so good. I pray that you really step ahead more and more. Thank you so much, Dr. Kamara and everyone else. I would like to thank all the members for coming in, listening to us, really asking questions, showing that they've understood. Yeah, that's so good of you, and I encourage us to continue the same spirit. May God bless all of us. Good day.
Amen. May God bless you too. Mrs. Hamida, do you have something to tell us, please? You're welcome.
Okay, members, thank you for turning up and really continuously learning. I believe, as we've seen, it's an interdependent management. All the professions and different cadres are needed because, as Dr. Orit has said, most of the patients actually present when it's late. There is very little you can do, and the management sometimes is limited because what you're doing is more of saving a life, but the person actually is dying. So with the knowledge, sometimes I think we can easily identify the risks and know what to do when, and perhaps resuscitate and refer easily or immediately in case we don't have all the interventions that can help save the patient. Thank you very much. I'm proud to be part of the session and looking forward to having more sessions and attending them because this was a great experience. Thank you, everyone.
Oh, thank you so much, Mrs. Hamida, and thank you all our experts who have taken us through this session. Dear members, we also appreciate your turn up. It's really been so good, over 200 plus. Next time, please share the link with your fellow colleagues in different health facilities. And we would like to also recognize those who have attended as a group from various hospitals. We appreciate your attendance so much. At this point, we request you to please turn on your camera so that we have a group picture together. Please turn on your cameras, your videos, so we can look at you and have a picture together.
Thank you all for joining in for today's session. I'd like to recognize the attendance of Commissioner for Emergency Medical Services, Dr. Wanyae, who is waving to us now. We thank you for attending. Thank you all for joining in. Our next session will be in 2 weeks. Please turn your videos and we can take a few screenshots. Yes. Scan your videos. Like to recognize the different react teams that are joining in. I see Dr. Mwanje Benjamin, thank you for joining in. Okay, thank you all for joining in. Dr. Wanyae, do you have any remarks for us as we close?
Just to appreciate, thank you so much for the great session, because upper GI bleeding is so common. Thank you for bringing these experts who have shared greatly with us. Thank you. Keep up.
Thank you very much, Doctor. So we'll meet again in 2 weeks. Thank you for joining in. We'll be communicating with you. We'll share the slides because who joined in on the session so that you can read through in case you need further clarity. And then we also have a WhatsApp group in case you have any questions with regards to today's session, any other questions that arise later. We'll try and forward those to the experts in case they're not answered by any of the other members of the group. Thank you all, and we'll meet in 2 weeks. Bye-bye. Bye.
Bye.